The following presentation is the assessment of the respiratory system. You may find that some of the assessments are present within the other system assessments. To undertake the respiratory assessment, you must know the anatomical landmarks and also have a sound knowledge of the respiratory physiology. Today, I have marked several of the anatomical landmarks. The sternal notch is present, and below the sternal notch you will find the manubrium, which is a raised prominent area. Either side of the manubrium you will find the second rib. The manubrium follows down the sternum to the xiphoid process. At the base of the xiphoid process are where the ribs meet. Other anatomical landmarks you will find are the mid-sternal line, the mid-clavicular lines, and the anterior axillary lines. A knowledge also of the lobes of the lungs are important when assessing the patient. The right lung has 3 lobes: the upper lobe, the lower lobe, and the middle lobe. The left lung has 2 lobes, the upper lobe and the lower lobe. So when we assess the front of Ian's chest, you will find you're mainly looking at the upper lobe and the middle lobe of the right lung, and mainly looking at the upper and slight lower lobe of the left lung. If I turn Ian to the side to the lateral view, you just pop your arm up please, Ian. You'll find once again that we have the upper, the lower and the middle lung on the right side. If we turn to the left side, thanks Ian, you'll find that we only have the upper and the lower lobe. Looking at the posterior area, you will see that we mainly see the upper and the lower lobes. The upper lobes you will notice above the T3 process. Another important landmark to know is the C7. Okay? This process will allow you to find the thoracic vertebrae, and from there you'll be able to ascertain the IC space in which you're percussing, palpating and auscultating. Thanks Ian, we'll just turn back around again. One of the tools of trade for your respiratory assessment is your stethoscope, and it's important to buy a stethoscope or have a stethoscope with a diaphragm and a bell. The stethoscope's tubing should be of minimal length to avoid extraneous noise. The diaphragm is used for high-pitched noises. The bell is used for low-pitched noises, but if pressed firmly against the skin will act as a diaphragm. When we undertake this assessment, we're going to look at history, inspection, percussion, palpation and auscultation. When taking a history on the patient, it's quite important to start off with the presenting symptoms of the patient, then moving on to family history, medical history and social history. After the history, we need to move on to the inspection phase. And when you inspect your patient, stand away from the patient and observe the patient's respiratory rate. This is an important process because if the patient is having difficulty with his breathing or is in pain, you may find that you may have to undertake the assessment in a different position. Ian's respiratory rate, as you can see, is between 12 and 20 breaths per minute. His depth of breathing is neither shallow nor deep. His inspiratory to expiratory ratio is approximately 1:1, which is quite normal. The other thing to observe on Ian is if he's using any accessory muscles at all for breathing. And at this point you can see that no accessory muscles are being used. So he has not got an increased work of breathing at present. We also look for symmetry, which is extremely important in your respiratory assessment. When we look at symmetry, we're watching to see that both sides of the chest are moving equally. The other thing we need to look at are Ian's hands. And if we move down, we can see that there's no sign of clubbing in this person. Clubbing can be a sign of respiratory disease when the nail bed angle increases greater than 160 degrees. Thanks, Ian. Also, with your assessment at the initial stage, you need to look at whether the person has a cough. If the person does have a cough, ask him to cough several times, and from that you can ascertain whether it is a dry or a moist cough. Also, you need to examine the sputum of the patient as well. When we assess Ian, we also need to assess for any scars or visible scars, and we can see Ian has had some past surgery, okay, for a bypass. We need to assess all areas, the anterior, the lateral and the posterior sides of the patient when we do an inspection. Other things we must look for when we do an inspection of Ian are for signs of cyanosis, and that is for peripheral and central cyanosis. Central cyanosis can be detected by looking at the patient's tongue. Thanks, Ian. And Ian has a nice pink tongue. Central cyanosis is a very late sign of hypoxia. Also with Ian, we need to look for any bony deformities, such as funnel chest or pigeon chest. And here we can see that the sternum is nice and flat. It's not protruding and it's not retracted at all. Also with Ian, we need to look at the posterior to anterior diameter. And so we can see here that his front diameter is about 2:1, which is quite normal. Any variation in that, you find that the person may have signs of a barrel chest, which is a sign of emphysema. The other thing we need to look for is for signs of scoliosis or kyphosis. And to do this, we'll need to stand Ian up. Thanks, Ian. I'll just turn Ian's side on to the camera. And when we're looking for kyphosis, you will see that we're looking for any type of hunch or hunchback. We can see here that Ian has no signs of this. When we look for scoliosis or a lateral deviation of the spine, we need to turn Ian around. Ian, can you just bend over for me slightly? By bending the patient over, you're able to see the cervical, thoracic and lumbar prominences more easily. We can see here that his spine is quite midline, that there are no lateral deviations. These conditions can diminish vital capacity or ability of the patient to ventilate. Thanks, Ian. If you'll just take a seat again. Okay. That concludes the inspection of the patient. We need to move now on to palpation. And when we palpate the patient, we will be using the tips or the balls of our fingers. When we do this, we're trying to feel if there's any pain or tenderness, see that we have continuous skeletal unity. Also, we need to look for crepitus, okay, particularly indicative of a surgical emphysema where you have a leaking of air underneath the skin. We'll also be feeling for any types of masses or nodes or nodules underneath the skin. When we palpate, we need to palpate, of course, the anterior, the lateral and the posterior aspects. I'll just palpate. Any pain at all?
No.
Tenderness?
No.
None at all? Okay. And I would do the same to the posterior areas. Also with palpation, we need to look at the thoracic expansion. And when we do this, we place our hands first on the anterior and then on the posterior regions and put our fingers pointing towards the person's axilla. You'll find that you need to pull your thumbs closely together, but the thumbs are actually off the skin. If you take a nice deep breath in now, Ian, and breathe out. We'll actually be doing thoracic expansion now. And when we do thoracic expansion, we need to place our hands so that our fingers are actually pointing to the axilla. We then move our thumb to the midline. And we'll ask Ian to breathe in, please, Ian. And now breathe out. You can see how my thumbs moved about 3 to 5 centimetres. They moved equally as well. If Ian had a lesion, it's possible that my one thumb may not move as far as the other. After doing that, we also need to look at the trachea and assess for trachea deviation. The trachea can be shifted under several circumstances. It can either be pulled or pushed. And those circumstances are pleural effusion, pneumothorax, lobe collapse. If I put my finger at the sternum and then push my finger down either side of the trachea, I can note that the trachea is actually midline. There is the same amount of space either side where my finger is sitting. Following the assessment of the trachea, we can also elicit vibration qualities via palpation, either using the palm surfaces of the hand or the ulnar surfaces. With this process, I'll ask Ian to pronounce the word 99. And when he pronounces this word, I'll actually feel the vibrations. So this is a tactile process, Ian. If the vibrations are increased, it is a sign that there may be consolidation. If they are decreased or diminished, we have an increased amount of air in your lungs. So it may be that it's an emphysema type process occurring. Of course, you're not going to say this to your patient. Okay, we'll start off, Ian. Say 99.
99.
99?
99. 99.
Okay. We'll turn you round to the posterior area now. Thanks, Ian. Okay, say it again.
99. 99. 99.
Okay. There were no increased vibrations while I was doing that with Ian. And that ends the palpation section. The next session is percussion. When we use percussion, it's used to detect the density of material underneath the surface of the skin. We might be looking at fluid or solids or air. The patient's lungs are usually filled with air and therefore have a resonant sound. If I were to percuss over a bony area, you would find that it would be a very flat sound. If I were to percuss over an organ area such as the liver or the heart, you would find it would be a dull sound. Again, over the lungs is a resonant sound, and if Ian had a tension pneumothorax, you would find that that would be a hyperresonant sound. Percussion sounds are described in pitch, intensity, quality and timing. When we percuss, you need to adopt the appropriate technique of putting your middle finger in the intercostal space and tapping that distal phalanges with your third finger on your right hand. It's if you're right-handed. When I tap, I make sure that the rest of my hand is off Ian's body, but I also tap with a very loose wrist. And I take my hand away quickly after I've tapped to maintain the sound. To percuss, we need to percuss the anterior, the lateral and the posterior sides. We're always comparing one side of the body to the other. This is quite important. I'm going to start around the second IC space and move down. Let's go down this side end. Thank you. To do the lateral sides of Ian, I need to move from side to side. Again, I'm comparing one side with the other. I'll turn you round, Ian. If you just pop your hands up for me. That's good. Comfortable?
Mm-hmm.
You look it. I'll move you around this side now. Down to the other side again. Oh, sorry, Ian. One more this side. Notice when I percuss the lateral sides, again, I'm quite wary of comparing the upper lobe with the upper lobe and the lower lobe with the lower lobe on both sides. To do the posterior section, it's quite effective to have Ian pop his hands across his chest, and that moves your shoulder blades out of the road. So I'm percussing either side of the vertebrae and comparing one side to the other. Other side here. Thanks, Ian. So the resonant sounds were detected throughout Ian's structures, except when I percussed over the areas where the lung is situated, the heart is situated, and where the liver is situated. Those areas were slightly dull. Now move on to the auscultation phase. In this phase, you'll need the stethoscope, as I described earlier in the session. When we auscultate Ian's lungs, we're looking at the quality, the intensity, and for adventitious sounds. By quality, I mean the normal breath sounds. And when we talk about normal breath sounds, we talk about tracheal, bronchial, bronchovesicular, which are located in the first, second, and third IC spaces, and fascicular sounds, which are located mostly over the peripheries of the lung. Again, we need to be mindful of the anatomy underlying structures when we do the auscultation. When I talk about intensity, I'm referring to diminished or harsh sounds, and I'll explain that further later. The adventitious sounds that we're looking for are crackles and wheezes. Crackles and wheezes are sometimes described as rhonchi and rales, but really you should be using crackles and wheezes to assess or to determine the nature of the problem. I'm going to auscultate the anterior, the lateral and the posterior sides of Ian now. Prior to auscultation, I'll ask Ian to breathe through his mouth. You'll find that if Ian breathes through his nose that the sounds do not transmit appropriately. So Ian, I'd like you to breathe through your mouth, take reasonably deep breaths, but you do not want the patient to hyperventilate. I'm going to be listening to the inspiratory and the expiratory phases as well. You'll find when I listen from the cricoid ring down to about the sternal notch in the tracheobronchial region, and I've combined the tracheal and bronchial regions together, we have quite harsh tubular sounds, where the expiratory time is longer than the inspiratory time. When I listen to those noises again, it's quite harsh. As I move down to the bronchofascicular areas, as I explained at level 1, 2 and 3 intercostal spaces, you'll find that the noise is less harsh because the air is starting to be filtered and has a more laminar flow. When I move to the peripheries of a lung, once again there's a larger surface area and a more laminar flow occurring in these distal airways. So it's quite a soft and a breezy noise that you will actually hear. And you will find that the inspiration time is slightly longer and inspiration and expiration are fairly continuous. I'm going to listen to the anterior section of Ian, starting up above the clavicle where the apices of the lungs are, and then again moving down about every 2 or second IC space. Okay, Ian. When I listen above the clavicles, I'll actually use the bell of the stethoscope, and I'll get you to take a nice breath in and out, please. That's good. Other side. Again, comparing one side to the other. That's good, Ian. Just going to change to the diaphragm now. And with the diaphragm, again, I'm going to move down about every second IC space. In and out. Breath sounds may increase in intensity or be diminished. The normal air-filled lung acts to filter sound. Changes in lung pathology will alter sound transmission. Increased lung density will increase sound transmission lung qualities and decrease the filtering effect. This occurs in consolidation via pneumonia or atelectasis. An obstructed bronchus via a mucus plug will block transmission of sounds. Therefore, diminished breath sounds would occur. Thanks, Ian. I'll just do the lateral sides now. If you pop your hands up on your head again, that'll be fine. Once again, I need to compare one side to the other side. So I'm going to do the upper lobe at the moment. That's good. We'll swing round, Ian. Thanks. Good. In this instance, I didn't listen to the middle lobe of the right lung, I just compared the upper and the lower bases. Again, how many sites you actually listen to will depend on your institution's guidelines. Just do the posterior area. And once again, it's a good idea to have Ian put his arms across, just nicely folded, whatever's comfortable. And that moves the shoulder blades once again out of the road. Above T3, so this is C7, T1, T2, T3. Above T3, you'll actually find the upper lobes of the lungs. The adventitious sounds, as mentioned earlier, include crackles and wheezes. Crackles can be fine or coarse, and they're caused by the popping open or fluid in the alveoli. Conditions in which this occur include pulmonary edema or pneumonia, and the sound usually occurs on inspiration. Secretions in the airways or alveoli may elicit this sound. Therefore, always ask the patient to cough and reassess the breath sounds. Wheezes may be inspiratory or expiratory, although they are usually expiratory. People who may have a wheeze include asthmatics. Stridor is another sound you may hear due to partial obstruction of the upper airways, and this may be due to a foreign body. The final sound is a pleural friction rub. It's caused by the rough surface of pleura against each other, similar to creaking old leather and usually present on inspiration and expiration. The rub is usually a lower pitch and of longer duration than crackles. Thanks, Ian. Thanks, Ian. I'll just pop you back around. I think the final note after we've completed our history, inspection, percussion, palpation and auscultation is that various other means of data collection can occur. Ian most probably would benefit from having a chest x-ray if he presented with respiratory symptoms, and also the respiratory system or the tidal volumes can be elicited via spirometry or the forced expiratory volumes. Also, the respiratory system ties in very closely with the cardiac system, and therefore we could look at Ian for signs of cor pulmonar, which is a right-sided heart failure due to a lung disease or lung processes. So finally at this, I must say that this is by no means a comprehensive assessment. There are many health assessment manuals present, and I really do advise that you research further and read further on the health assessment of your patient. Thank you.